I thought this question was rather interesting because it's orthopedics. It spoke to me, but we don't do anesthesia in our office. So I thought that was rather interesting to have an anesthesia in the office code. I'm sure there are facilities out there, whether they're they meet the definition to be an office, but yet they're included in some part of a ASC center or something like that, where they might have the ability to actually have an anesthesiologist in their office. Um, well, I don't have the answer sheet. Okay. So a 17-year-old patient came to the orthopedic office after falling off their skateboard. So this has to have just happened because he suffered a closed fracture of the left fib, left tibia and fibula, as well as a severe sprain to the right wrist. So the patient was in severe pain. That's why I think it just happened. They're in so much pain. So the anesthesiologist administered anesthesia to him while the physician reduced the fracture. So it had to have just happened because that fracture needed to be put back together. The bones needed to be put back straight. And then they applied a cast to the lower leg. I thought that was rather interesting too, because typically right after a fracture, we don't apply a cast. You apply splint and do a cast a couple days later while you let the swelling go down. But, everybody does their own thing. So their question was regarding the anesthesia code 01462 versus 01490. Is there a rule for which is it the procedure or the casting? So I talked a little bit earlier when we talk about these global fracture codes or these surgical codes, our 90-day global period. So the same thing falls for our fracture codes. Now, you didn't perform surgery on them, but that's how your bill is going to come back to the patient, and they're all going to say, I didn't have surgery, I broke my foot. Well, it's kind of all the same thing. But that orthopedic is going to submit a charge for the closed fracture of the left fib. And that service is going to include it on that data service. When he sees this patient and bills a global charge, it's going to include a global procedures along with it. So all of the follow-up E&Ms for the next 90 days, they're part of that charge. We're anticipating seeing this patient again multiple times for this problem. That's why they get paid so much, because the work is involved continuing for 90 days. Casts on the first date. The first date of injury, the cast is included in that global surgical charge, that procedure code that we're going to bill. An injection to numb an area is included. This is a little bit different because we're giving anesthesia. We're not giving an injection. Sometimes they do that. They give an injection to numb the area before they try and put it back together. It just depends on the type of patient. Maybe they have some other conditions or something. So however, the service provided for anesthesia is being performed by another provider. Now you'll know in some CPT codes, the physician cannot perform the anesthesia themselves. There are some codes that specifically say the anesthesia provided by the provider or anesthesia by somebody else, by an anesthesiologist. So they break some of those codes out. So it's possible that these two might be under the same tax ID number, which comes into our billing aspect. But it's possible, like if they're in some kind of large building with a lot of different services, they called somebody in to help them. Either way, you will see in the end. So with all CPT services, we use the code that's most descriptive of the procedure performed. Now, we talked about this a little bit with the preventative and diagnostic. Or a lot of times they go in to do a scope just to see, and then they go, okay, great, now we need to open them up and do some kind of surgery. You're not billing for that small scope, you're billing for the more inclusive procedure, the most prevalent procedure given that day, which would be opening them up and doing whatever they needed to do. So in this case, the patient was in pain with their leg fracture. not the cast. The cast isn't giving them the pain. The leg fracture is, that's required manipulation or reduction. The doctor is going to do a little bit of twisting and turning there in order to set those bones straight prior to putting a cast on it. So the two codes they gave us were 01462 and 01490. They're both anesthesia codes. The 01462 is anesthesia for a closed procedure of the lower leg, foot, or ankle. And the 01490 is anesthesia for a lower leg cast application, removal, or repair. Our most prevalent procedure here, and the patient has pain because of that fracture, he's going to reduce that fracture and manipulate it. So that is our more prevalent code, so we do the 01462. So just for fun, because I got to the answer so quickly, I decided that we're gonna go ahead and code the whole rest of this note. So we don't know a whole lot of information, so I'm gonna make a little bit of assumptions here, just because this is what the field that I'm familiar with. So the provider would also most likely document that additional evaluation and management for that severe sprain of the wrist. So they saw them, they got the history, the HPI, they did an examination of the leg, and they probably could tell right away, it needed to be repaired. It wasn't sticking through, it's a closed fracture, so it's not poking through the skin. That would be an open fracture. So, but there's something wrong with the wrist as well. Well, we need to do an examination there. We need to figure, make a medical decision making regarding the wrist too. So they would most likely be documenting all a separate E&M charge. It's on the same date. So we have an E&M on the same date as a procedure. Again, I'm going to jump back to that modifier 25, a significantly separately identifiable E&M on the same day as a procedure. So they're most likely going to code 27752, which is a closed treatment of a tibial shaft fracture with or without the fibula fracture with manipulation. They have to reduce it, so they have to manipulate it, and that's with or without a skeletal traction. Now, they came to the office. This is right when it happened. We have to take x-rays. So we have a 73590, a radiological exam, tib, fib, 2 views. It's the only code option to choose. Our diagnosis is going to be an unspecified fracture of the shaft of the tibia left, initial encounter. It's the first time we're seeing them. We use that A for initial encounter, and then an unspecified fracture of the shaft of the fibula left, initial encounter. We can do that office visit. I'm going to make a little assumption. We'll just do 99202, just kind of its minimal decision making here because it's just a sprain. So they're probably going to put a brace around it or something like that. And I'm going to assume they're new. So an office visit new with a 25 modifier. It needs to have that modifier on there because it's the same day as a procedure. And we want to make sure we're paid for both things that we saw the patient for that day. Well, we're probably gonna have to take an x-ray of that wrist too and make sure that didn't break, make sure there's no fracture there. So 73100 wrist, you do have an option of 2 view or 3 view. I just picked 2 view. And then our diagnosis code is gonna be an S63.501A, an unspecified sprain of the right wrist, and it's our initial encounter. Now, our procedure code that we had for the anesthesiologist, whether they're in the same practice or not, same tax ID or not, you can bill for that anesthesia code, the 01462, along with the orthopedics providers. Problem was on a separate claim, but they don't run up against an NCCI edit. You are able to bill the anesthesia as well, and the global fracture care code as well.
Do you need more medical certification and business training? Learn more at www.cco.us.